Hello everyone, I'm Stuart Jarvis and I'm a research fellow at the Martin House Research Centre. Today I'm presenting some work we did as a systematic review looking at whether there is a change in healthcare use at the transition from children's to adult healthcare. Now, first of all, a bit of background as to why we might think there might be a change at transition and why we might be concerned about this. Previous work has shown in a research prioritization event that the Centre ran a few years back, previous national reports, and in recent papers, that there are many concerns among parents and young people with life-limiting conditions about the transition, and particularly about access to services which may suddenly be less available or harder to book in adult care than they are in children's care, and also about GP experience, whether they have experience in the sometimes quite rare conditions that the young people have, and whether they might actually be pushing some young people and their families to go straight to A&E rather than coming to them. So there are reasons to think that there might be changes at transition. We formulated a review question which was quite broad, looking at whether there was a change in health or social care use for young people with life-limiting conditions post compared to pre-transition. We made this quite broad because we weren't sure quite how much literature was out there, and we thought that any changes at transition would be of interest. Now, this question doesn't fit into the traditional PICO framework for systematic reviews, so we instead use a population exposure outcome framework. The population was young people with life-limiting conditions who had been treated in children's and adult services, and we limited to OECD countries to maximize comparability between studies. The exposure was the transition from pediatric to adult healthcare. This could be outpatient or inpatient care, or indeed primary care. And the outcome was any measure of health or social care. We identified some outcomes in advance, for example, inpatient admissions, A&E visits, primary care consultations and costs, but we're interested in any measure of health or social care use. We formulated a search strategy based on the population exposure and outcomes, with 3 search concepts: life-limiting conditions, children, young people, and transition. We didn't include the outcomes in the search concepts because we didn't want to limit the studies retrieved by trying to find particular terms for outcomes, particularly as we had left the outcomes quite open to any health or social care use. To be included initially, a paper had to match the search frameworks for each of these 3 concepts. Life-limiting conditions was based on a pre-existing search strategy for life-limiting conditions. The other 2 concepts were developed from previous strategies in the literature. We searched Medline, M-based PsycInfo, CNR, and the Social Science Citation Index, and this resulted in just over 18,000 papers matching the search strategy. After removing duplicates, we were down to 11,500 papers, and title and abstract screening reduced this to 235 papers potentially of interest. After full text review, we had 19 papers to include, which described 18 distinct studies. And I'll briefly summarize the 18 included studies. They covered a range of conditions, the most commonly studied being cystic fibrosis with 5 studies, followed by renal conditions, including things like kidney failure, with 4 studies, cerebral palsy, HIV, sickle cell disease, and spina bifida. And 2 studies looked at multiple conditions. Study designs varied, with 10 being longitudinal and 8 cross-sectional. And a range of outcomes were looked at, including outpatient attendance, inpatient admissions, inpatient bed days, numbers of courses of IV antibiotics, access to physiotherapy, access to HIV care, overall healthcare costs, and number of GP consultations. The studies differed in the ways that they ascertained transition, i.e. whether individuals were in pediatric or adult care. 9 studies did this through medical records, so they had a record of when someone transferred. The other 9 used a simple age cutoff. Now, studies were dominated by research from North America, so there were 7 from the United States and 5 from Canada. There were 2 each from France and Germany, and 1 each from Australia and the United Kingdom. When we came to synthesizing the results, there was too much heterogeneity in the outcome measures and the studies and the populations and the conditions to make a meta-analysis feasible. So instead we looked at alternative synthesis methods, and we settled on p-value combination and Verb counting. And these are illustrated in the graphs here. So I'll just explain a little bit about the graphs. The top graph is called an albatross plot and is a graphical way of presenting p-value combination. This plots p-values in each effect direction for included studies against sample size. So on the left, you have studies that showed fewer events for a particular outcome. On the right, you have studies that showed more events for a particular outcome. And as you move towards the bottom left or bottom right, you have stronger indications of either fewer events on the left or more events on the right. The curve guidelines show you where a study showing a particular effect size would fall depending on sample size. So if you have a larger sample size for a given effect size, you have a smaller p-value and you move more into the extreme corners of the graph. At the bottom, we have what are called harvest plots, and these are just bar graphs which show in each individual bar a single study, and the height of a bar shows the quality score of that study based on the Newcastle-Ottawa score. In the left panel of the bar charts, we have studies showing fewer events, in the right panel, studies showing more events, and in the middle, if applicable, any studies that showed no change. So moving to our first outcome of interest, which was outpatient attendance. There were studies showing effects in both directions. On the albatross plot, you can see studies on the left and on the right, and also studies in the bottom left and towards the bottom left and bottom right corner showing strong evidence. And there was strong evidence from p-value combination for both a decrease in outpatient attendance post-transition and an increase in outpatient attendance. This was split by country. If you compare the United States and Canada, there's only strong evidence in the US for a decrease in outpatient attendance, and there's only strong evidence in Canada for an increase in outpatient attendance. And this is backed up by the harvest plot below, showing the number of studies on each side, which is quite evenly split. Moving on to second outcome of interest, which is inpatient admissions, there is again strong evidence for both an increase and a decrease. But again, if you split this by country, Canada only shows strong evidence for a decrease in inpatient admissions of the United States, and it shows strong evidence for an increase in inpatient admissions. Looking at A&E visits or emergency department visits in North America, there's only strong evidence for an increase, and this is not patterned by country. For inpatient bed days, there's again strong evidence in both directions, although not a large number of studies included. Only 4 studies in total looked at this, and only 3 had p-values or for which p-values could be derived. There's no strong evidence on numbers of intravenous antibiotics administered pre or post-transition. There was evidence for a reduction in the number of people receiving physiotherapy post-transition compared to pre-transition, but again, this is based on a small number of studies. And there's evidence in both directions on healthcare costs, again, based on quite a small number of studies. So to summarize, the evidence overall was mixed and conflicting, with strong evidence on many of the outcomes, both an increase and a decrease after transition compared to pre-transition. There was evidence overall for an increase in A&E visits and reduction in access to physiotherapy. There was evidence of differences between the United States and Canada in inpatient admissions and outpatient appointments, where the strong evidence was in different directions, depending on which country was studied. But inconsistent measures and poor ascertainment of transition do mean that more research is needed. The outcomes were measured in many different ways. Some studies looked at means, some at medians, some looked at odds ratios from regression models. And a particular concern was that the studies fell into 2 main groups. Some used population data, but tended to use a simple age cutoff to assign people to children's or adult care, with a consequent risk of misclassification bias because it's not normally that simple. There were smaller studies in single clinics or small groups of clinics where medical records were used to determine when people transitioned, but these clinics may not be representative of the overall population. So there is a need for more research in this area, and this is something that I'm presently working on within the centre. The full paper is published for a systematic review and it's open access, and it's available at bit.ly/transSR. Thank you.